Hello, welcome everyone. This month, the Office of Diversity, Equity, and Inclusion is happy to be hosting disability awareness programming and events. And I'll begin by introducing Dean Amy Campbell, who is moderating our event today, and then she will introduce in turn our speaker. UIC Law welcomes Dean Campbell as its Associate Dean for Law and Health Sciences and one of the newest member of our tenured faculty. Dean Campbell joins UIC Law from the University of Memphis School of Law. Dean Campbell specializes in health policy, health justice, and health equity with a focus on the role of policy in preventing childhood and community trauma. Her law school-based teaching experience includes health law survey, mental health law seminar, bioethics and the law, and public health law, and an interdisciplinary policy skills course she developed, the Health Policy Practicum. Her current scholarly interests focus on how to advance health equity through a multi-sector structural reform strategy directed at racial and economic inequities, and how to develop health policy from a therapeutic, evidence-informed, and ethical perspective. At USC Law, Dean Campbell is working to build dual degree and other collaborative programs with UIC's 7 health science colleges, as well as developing the law school's JD Health Law curriculum. And we are so excited for those programs to exist and for students to start taking advantage of them. So without further ado, Dean Campbell.
Thank you so much. Thank you. And that's a very generous and kind introduction, but let's get on to the introduction that matters for our next hour. I'm delighted to introduce Dr. Christie Kirschner. You see here her affiliation with UIC. She's a clinical professor in the UIC College of Medicine, Department of Medical Education, where, as you can see, she also holds secondary appointment in the Department of Neurology and Rehabilitation Medicine. She also is an adjunct faculty member in the Department of Disabilities and Human Development in UIC, where she worked to co-create the Certificate in Disability Ethics in 2003. As a physician, she specializes in physical medicine and rehabilitation, with particular interest in the needs of patients with complex neurological disabilities. She's a graduate of the University of Chicago Pritzker School of Medicine, where she also was a fellow at the McLean Center for Clinical Medical Ethics. Prior to coming to us for our benefit at UIC, she was on the faculty of the Northwestern University Feinberg School of Medicine and was also the founding director of the Donnelly Family Disability Ethics Program at the Rehabilitation Institute of Chicago. From 2010 to 2019, she practiced at the Schwab Rehab Hospital, which is on the west side of Chicago and is a safety net rehabilitation hospital. But she left that and her clinical practice there to work on complex care and structural reform or structural issues in health reform. So we are so delighted that she brings that expertise to us today for this really, I think, informative discussion that we'll engage in. And with that, I turn it over to Dr. Kirschner.
Thank you, Dean Campbell. I am so thrilled to be here today. I'm so thrilled to be developing relationships with the John Marshall Law School, because a lot of my interest is actually in health equity, human rights, civil rights, and how we can work together across our schools to try to promote these issues. So I'm going to do a bit of a whirlwind overview to start. I don't know how many of you are really familiar with the portrait or the snapshot of who people with disabilities are and where we were prior to COVID. CDC website is a really nice place to go if you want to read more and dig deeper. But right now, it's about 1 in 4 non-institutionalized adults live with a disability. These are the disability census questions. The largest percentage is people with mobility disabilities, followed by cognitive disabilities. When you break it down by race and ethnicity, you will see that 3 in 10 American Indians or Indigenous people have a disability, followed by Black citizens with a 1 in 4 disability. So we can see that there are certain populations that are disproportionately affected by disability, and there are also differences in issues of obesity, smoking, and the rates of chronic illness and disability associations. There are significant issues in terms of healthcare access. This particular survey looked at who didn't have a regular source of healthcare services, who had unmet needs, who didn't get a routine checkup. So these are very significant numbers of difficulty with disability access. There is a higher incidence of chronic conditions, obesity, smoking, physical inactivity for people with disabilities. People with disabilities are more likely to be under publicly covered health insurance, meaning Medicaid or Medicare. The populations I care for, who are some of the most complex with neurological disabilities, are overwhelmingly in Medicaid. Many are high utilizers of healthcare services. They are more likely to be admitted to the hospital, and there are still significant issues of cost that interfere with their ability to get care. Poverty goes hand in hand with disability. And they're less likely to find employment, their educational levels are lower, and of course, all of these issues are going to affect social determinants of health. The population of people with disabilities may be in waiver programs in order to get home and community-based services or long-term care spending. Illinois is still lagging behind home and community-based services. I've tried to find updated data, and it's actually gotten increasingly difficult to find this information on websites. But we know that Illinois is still one of the worst states in terms of home and community-based services. So in terms of my journey, Dr. Campbell, or Professor Campbell told you a bit about it, but I'm just going to highlight, I worked on the Gold Coast for much of my career. I did my residency. I was a medical student at U of C. I went to Northwestern for my residency. I stayed on there at one of the elite rehab hospitals, which at the time was called the Rehab Institute of Chicago. I had a faculty status in medical humanities and bioethics. So 20 years of my life was spent there. But I became increasingly concerned about the fact that what were the most pressing moral issues in ethics weren't the issues that were being addressed in these rarefied environments, the issues of access and health equity. I moved to Schwab in 2010 to focus on the issues of access and health equity, particularly for people in the Medicaid population. So this is my environment on the right side in terms of, I would drive past, rest in peace, John. This is my Schwab hospital. When I compared access to food sources, it was a food desert. So it was a really interesting, sort of picture for me to move from one setting to another and see how wildly different the resources were. And since 2015, I've been at University of Illinois. You can see here, we're 5.5 miles apart. I wrote an article at one point called One City, Two Worlds that unpacks that a bit. But again, as I was saying, a lot of the issues in traditional health ethics centers are these more rarefied issues. And I think arguably the most pressing issues, the ones that affect the most people, that are the most pressing for society, really are health equity and access issues. When I dug into this deeper, just simple things that, are really, truly troubling. Why is it African-American patients with muscular dystrophy are dying 10 years younger than Caucasian counterparts? What's going on here with this, huge reduction in life expectancy for people with serious mental illness? A lot of my work had been around reproductive health care services for disabled women. We still have fairly recent data that they're still being denied access to services because of their disability and lack of accessibility of the health professionals' offices, less likely to receive preventive health care services. At Sinai Health Systems, we had the Sinai Urban Health Institute, which has done fabulous work documenting census level data in the Chicagoland area and doing door-to-door surveys. This data on the difference between, I think it's 8 years, based upon the most recent data I've seen, Black men and Caucasian men in Chicago, the breast cancer rates of African-American women and the death rates being higher. This statistic on a quarter of the children in North Lawndale having asthma, the incidence of diabetes. So all of these comorbidities are important as we think about disability. When I first moved to Schwab, one of the things I did was dug into our stroke data because I'm seeing outpatients and I'm realizing I am seeing a huge number of young people with strokes. What's going on here? Stroke is supposed to be a disease associated with older age. When we did 100 chart reviews of stroke patients before the Patient Protection Affordable Care Act, we found that our mean age was 60 compared to the mean of 70 nationally. And a much larger percentage of those were uninsured at the time of their stroke. So think about people who didn't have treatment for their hypertension, their diabetes, and then they get their stroke and they were suddenly in the healthcare system because of their disability status. So the Patient Protection Affordable Care Act really began to change that landscape a bit. Another issue at Schwab that was very interesting to me were the demographics of the spinal cord injury unit. And my colleague there, Dr. Ray Lee, who runs that unit, actually compared what we saw at Schwab to the national database. And as you can see, much higher rate of Black patients, and the primary cause is violence. So I want to put this also in the context of the disability civil rights movements and what has changed in our country, because it's been a very wild 50 years in terms of civil rights in general and human rights in general. But disability civil rights also grew out of the 60s. We started to have independent living centers in the 1970s. We started to get our disability civil rights laws. The Society for Disability Studies was founded in 1986. And for those of you who don't know, University of Illinois has a very proud heritage in this regard and was the first PhD program in disability studies. So we have a gem, a resource at UIC that I think is important for us to mine. We got our sweeping civil rights legislation in 1990. So one of my mentors and colleagues, Paul Longmore, began to write about medical culture and disability culture and what he called the clash of cultures. So this is Paul here on the right. Paul had polio as a child, post-polio syndrome as he aged. He's a historian. He was a professor at San Francisco State University. He's one of the fathers of disability studies. And when we began to have all these ethics cases in the 70s and 80s, Paul began to realize disability was a common theme. And the way health professionals and ethicists saw disabilities wasn't the way he and disability activists saw disabilities. And he wrote this article that I consider a real classic called The Clash of Cultures. And he talks about the difference in values and perceptions. So the major obstacle he sees in medical decision-making in the healthcare setting is that the perceptions and values of people with disabilities don't match those of non-disabled people. We don't understand each other. And this bears out in the way we think about treatment decision-making, healthcare access, rationing, and the way we talk about healthcare ethics issues. He talked about how, you know, the differences in opinion also stem more basically from the clash of fundamental values. He and many others have seen the helping professionals as almost adversarial to the goals and the interest of people with disabilities. Not Dead Yet grew out of the physician-assisted suicide movement, you know, the lack of disability access in some of our legal environments, the crawl up the Capitol porch steps, people with disabilities who were being placed in nursing homes against their will because they didn't have access to home and community-based services. So all of these issues were issues that Paul was writing about. And if you think about the genesis of disability studies as a field, they began to talk about the differences between the medical model and the social model. So the medical model, also known as the deficit model, is that disability is always negative or pathological. It resides within the individual, and our job as health professionals is to try to cure, prevent, or normalize the individual with disabilities. And even the rehab goals are focused on normalization and trying to help restore the status of the individual in society so they can resume normal life roles and goals. So this is individual based. Person with disability may be maladjusted because of their disability, and the medical professional is always the expert. Disability studies has talked and dug into the social model of disability and how a different lens or a different frame makes us look at the problem of disability very differently. So disability is a difference. It's not necessarily good or bad. It's a normal variant of our humanity, of having bodies, of being people, and that the stigma that results from having a disability is a result of social attitudes. That disability resides in the interaction between the individual and society, that the solution is often to change society, and that the expert isn't necessarily the professional. It can be another person with a disability. It can be anyone that can help to advocate for social change. So those principles have been very important in the conversations about where people with disabilities are in relationship to the medical and health system. And in 2019, the National Council on Disability commissioned this series of bioethics reports. So it tells you that these problems haven't gone away. These are still very prominent issues of concern for the disability community, and these 5 reports are excellent. I would encourage you, if you want to drill down and read more, they're really invaluable. And if you look at quality adjusted light years and medical futility, I want to highlight this too, because those reports serendipitously came out right before COVID hit. So we're talking about the fall of 2019. I'm going to refer you all to also the Disability Rights Education Defense Fund website to look at their Healthcare Stories videos. These are interviews and discussions with people with disabilities about their issues and concerns about relating to the healthcare system. But I want to end my whirlwind overview by just summarizing a couple points. That people with disabilities don't have a particularly favorable sense of where they stand in relationship to the health professions. There's this concept of the disability paradox, that health professionals, non-disabled people routinely underestimate the quality of life of those with disabilities. That people with disabilities are higher users of healthcare services. They're not very happy with the care they receive. Sometimes they just simply avoid coming to see health professionals because of prior adverse experiences. This is another whole topic, but healthcare institutions, in my opinion, have been the laggard when it comes to compliance with the ADA. Interesting question, why is that? Many are just simply not still prepared to meet the needs of people with disabilities. We have an increasing number of class action lawsuits occurring around the country because hospitals did not change. Healthcare professionals still don't get very good training about disability, and we're constantly working to increase the quality of education and to think about stigma, ableism, disability bias. People with disabilities don't often feel respected as partners in their healthcare, or that they're experts in their body and consulted about their needs. So there's a lot of lack of trust, which goes to the heart of what How Longmore was also trying to call out. So I'm turning now to COVID. That's where we were prior to COVID, then COVID broke. So 2019, December 31st, we got the first report for the Wuhan Municipal Health Commission, a report of this cluster. By January 21st, we had the first known case in the US. Today, of course, we all know we're dealing with 8 million US cases and 217,000 deaths, and the numbers are rapidly rising as we speak. So what do we know about COVID and the impact of COVID on people with disabilities? Where's the data? Well, one of the first issues is there isn't much. We're talking about still an invisibility of the outcomes of people with disabilities during COVID. And we're gathering some data, We know from the prior data I shared with you that there are lots of issues of intersectionality here that we need to be exploring as we look at COVID outcomes. But because we don't collect that data, it's really hard. So there was a lot of advocacy efforts about trying to make sure that we're collecting data so we understand COVID outcomes. In the Paycheck Protection Program and Healthcare Enhancement Act back in April, we were able to get race, ethnicity, age, sex, geographic region, disability did not get explicitly called out in this act. So there's still advocacy efforts going on. A group of us through the Disability and Rehab Research Consortium advocated with Alex Azar to call out disability as another need area. We've written to state legislators and to federal legislators. So far, we still have not had success in this regard. So what we're having to do is we look at the current data that we have. We see that African Americans, Indigenous people are disproportionately affected in terms of rates of infection, in terms of death rates. Latinx people certainly have higher rates of infection and hospitalization. We know that comorbidities are highly correlated with the outcomes that we're seeing from COVID. And remember, people with disabilities have higher rates of comorbidities. So we look at age. There's a significant increase in terms of worse COVID outcomes with aging. But we're having to extrapolate when it comes to people with disabilities. So I'll tell you that in long-term care, we know about 40% of the deaths nationally have occurred in long-term care facilities. In Illinois, it's higher than 50%. That's huge. I would posit that everyone in a long-term care facility has a disability to qualify for that level of care. So we know something about long-term care and the COVID impacts on people with disabilities. What about people with intellectual and developmental disabilities? Well, New York has been digging into this data some, and they found that 16% of people who get state services with intellectual and developmental disabilities have a higher fatality rate, 16% versus 6% for the overall fatality rate. And these numbers have also been looked at in Pennsylvania. So people with intellectual and developmental disabilities seem to be particularly disproportionately affected. So we're really still struggling to understand the full picture and impact the issues of intersectionality, but people with disabilities are a population we should be concerned about. So what's a second issue of concern when it comes to COVID and people with disabilities? Well, right off the bat, issues of stigma and bias were a concern. And that came to the fore because of crisis standards of care. So states, hospitals, public health departments are scrambling at the beginning of COVID when we began to anticipate the flood of patients and the needs to think about, well, what happens when we have more need than we have resources? And so a lot of the modeling initially occurred around ventilators, around ICU beds. You had ethicists getting involved, trying to think about, well, what are our goals for crisis standards of care? Are we trying to save the most lives? Are we trying to save the most life years? Are we trying to predict who's most likely to benefit? How are we thinking about people who have been more disproportionately at risk because of the kind of work they do? All sorts of things were being vetted and talked about. So when I talk about crisis standards of care, this is a good basic chart that you can use. Hastings Center has some wonderful materials here, but you're thinking about what's the stuff you need, the space that you need, and the staff that you need. So those are the resources that you're evaluating. In conventional, you're appropriately staffed, you have everything you need. As you start moving to contingency, your emergency stockpiles are drawing down, you're beginning to have to repurpose spaces, you have to bring in external staff. As you continue to move to the right, you may have to get staff to begin to learn or retrain to do atypical staff. You're in this reuse. So we've certainly had a lot of discussion about PPE and how we have to reuse critical supplies because they're inadequate. And then you get to frank, catastrophic care where we simply have to acknowledge that we don't have the resources, we don't have the staff, we don't have the equipment, and we've got to frankly triage. So lots of work and writing, again, by disability activists about these issues. This is Alice Wong. She's got a wonderful website on the Disability Visibility Project. She's written a lot about this, but I wanted to just call out, you know, in terms of the feeling of vulnerability prior to COVID, it was clearly there. You know, attempts to repeal the Affordable Care Act, pre-existing conditions, you know, questions about human gene editing, you know, the impact of the environment on the health and well-being of people with disabilities, the power cut shutoffs that people in California were experiencing, then Arkansas Medicaid work requirement. So lots and lots of issues and concerns prior to COVID. And then we're in this period where we're trying to write these standards of care. Now, she's a ventilator user. She has spinal muscular atrophy, and people begin to talk about, you know, where are people with chronic disabilities in the mix? Could you even take a ventilator away from somebody who's a chronic ventilator user and repurpose it for people with disabilities? So the stigma and bias that was being built into the triage schemas for crisis standards of care, ventilator rationing, was a huge concern. There were concerns about lack of accommodation. So, you know, if you didn't have great accommodation policies prior to COVID, what do we expect during COVID? Immediately, visitors were being restricted in hospitals and emergency room. People with disabilities, particularly with communication disabilities or intellectual disabilities, may rely upon a support person to help advocate for them, provide history, to help them communicate, make sure that their disability-specific needs are being met. If you can't have a visitor with you, you're very vulnerable. You know, if you're a person with a disability and you can't use a traditional call light because you have hand weakness, what kind of call lights are available to you? Are you going to be in spaces where you can access the care you need if you are in a hospital? If you're not in a hospital and you're getting sick, where can you go to get COVID testing if you're disabled? Where can you get your medical care safely if your clinics are closed down? You know, it took a long time for telehealth to wrap up. Many home health services were being disrupted during the period of early COVID. And I'm going to get to the issue of the direct service workers and the personal assistance care. But 11 states that had their crisis standards of care in place deprioritized people living with disabilities. So there would be exclusionary criteria or categorical exclusions. This could disproportionately harm older adults, you know, people with severe dementia, advanced and treatable neuromuscular disease, like Alice's spinal muscular atrophy or muscular dystrophies, people who need some level of assistance with activities of daily living. So these categorical exclusions were a huge concern. And if you want to read more, a good summary is on this Justice and Aging website. But immediate complaints were filed. So again, the disability activist community is well organized, and they're on top of lodging complaints when they see a lot of this. We had DRADF, the Disability Rights Education Defense Fund. We had ARC. We had independent living centers. We had a number of organizations working together to immediately lodge complaints about this. Office of Civil Rights got involved, and on March 28th, they issued a directive that people with disabilities should not be denied medical care based upon stereotypes, assessments of quality of life, judgments about their worth. They basically said, do not discriminate and do individual level assessment. So that guidance was provided by the Office of Civil Rights. But then you have to say, well, how do you take that guidance and close the gap with healthcare systems that haven't been particularly disability savvy to begin with? So many of these crisis standards of care and triage mechanisms wanted to use objective scoring. They wanted to use tools that existed to try to say, well, how sick is somebody? who's most likely to medically benefit. So SOFA, the Sequential Organ Failure Assessment, has been one tool that has been widely adopted. It was developed for sepsis, which has many similarities to advanced severe COVID, which has severe lung involvement that oftentimes looks like ARDS, or acute respiratory distress syndrome. But this tool was developed not for the emergency room, not to triage people prognostically. It was used to follow people already in the intensive care unit with sepsis, hadn't been tested on COVID. So that was a concern, because some of the metrics look at physical, neurological, cognitive, verbal functioning. What would happen if you came in with a chronic disability that affected your baseline measures? Would you be disproportionately disadvantaged? There's another scale I've been digging down to recently, this palliative performance scale, because certifying people as hospice appropriate has also been happening during COVID. And I've seen this scale used. And so I want to share with you just a little bit about what I think is disability bias built into the scale. So you've got this idea that people who score less than 70% may be hospice appropriate. It still says use your professional judgment, but this is what the scale looks like. So if you're paralyzed, if you're dependent in your care needs because of a chronic disability, you're going to be down here. Okay, so you can begin to see how your chronic basal disability may disadvantage you when you look at this scale. I've been doing some digging again in the literature. I don't believe there's any norming on people with chronic prior disabilities, nor caveats that people should be careful in using it in that population. So going back to where Alice Wong was and the concerns, this case has been out there in the news. I would encourage you to read and see what's written about it. But this man who had a pre-existing disability is in a Texas hospital with COVID. The hospital deemed further treatment would not be beneficial. So there's a great NPR story on him, as well as this Washington Post piece. And there's also available on the web in a YouTube audio tape where his wife had recorded this conversation with the physician, you know, where he basically said, do we want to be extremely aggressive? Do we feel like this would be futile? The question of futility is a big one. Will it improve his quality of life if we treat him? What will it improve? Will it ultimately change the outcome? And the physician said no. And the wife said, why would you say no to all of those? And he said, because right now it's quality of life. He doesn't much have one. And she says, why? Why do you say that? Is because he's paralyzed? He had a brain injury? You don't think he has quality of life? And the doctor said yes. So I think that gave credence to the fact that there were reasons to be concerned. This problem is particularly thorny in my mind because of implicit bias. You know, if you're being told don't discriminate, do individualized assessment, but you don't realize that you have biases, then how do we deal with that in any kind of triage schema? So the third area I want to call out here in terms of concerns for people with disability was the lack of visibility in the planning in public health prevention, community supports. So if you look at Chicago, Cook County, Illinois, you know, we started to plan for decompression strategies right off the bat. We built out McCormick Place to be an overflow facilities. If people were too sick to be at home, but not sick enough to need hospital level care, they could go to McCormick Place. But you had to meet certain criteria, and people with disabilities or certain weight categories would not be accommodated there. You had hotel rooms that were being picked up and available as decompression strategies. But again, not if you had disabilities. So where were people with disabilities in the planning for decompression needs. We had people in long-term care, we had people in group homes, you had people at home with family members, sometimes in crowded conditions. Somebody would have COVID in the home. If you needed to get them out of the home, where would they go? Would they have to go to the emergency room because they required personal assistant services? Would they end up in a nursing home, which was oftentimes the last place we wanted people to go? We had the problem in terms of the PPE and mitigation strategies to try to prevent people from getting sick. So when you looked at people in their home with disabilities who were at higher risk for COVID complications, many of them required undirect service workers. You had people who required training in the infection control practices. There hasn't been a program or a plan in place to try to address these needs. And right now in Chicago, we have PPE for people with disabilities, which is essentially charity care, trying to meet this need through crowdsourcing of material. There's a lot of advocacy work still going on with the state, with state legislators, to try to get a formal system in place to make this part of our pandemic planning, but still hasn't happened. Hospitals, you know, you think about this issue of the visitor policy that I called out earlier. You have hospitals that weren't prepared for many issues of disability accommodations prior to COVID, and then you've limited the visitor policies. There's been a lot of work on this, and there have been some progress, including OCR, encouraging hospitals to adopt such policies as a reasonable accommodation for a person with a disability. So some progress on that front. In terms of trying to think about this resource allocation problem, so we've got some rapid response team work taking place around race and ethnicity, particularly in the city of Chicago, geographic zip codes that are disproportionately affected. You've got theories of justice at play here, and we're seeing this now also play out when it comes to COVID and vaccines. So how are you going to address the fact that many people who are disproportionately affected by COVID were disadvantaged prior to COVID? You know, people who had more comorbidities, obesity, diabetes, because of health disparities, unequal access, structural issues beforehand. Should we be moving them to the front of the queue to get care? Should there be some sort of weighting factor to level the playing field? That's an area that I think really is important consideration. These take a long time to play out and to get in place, but I think it's part of what we need to be thinking about. I mentioned the problem with the direct care workers. This is an article, a blog post that we wrote calling out this problem. So you've got people with disabilities in the home. You've got direct care workers. These are people who oftentimes are some of the lowest paid in the healthcare system. They're like the CNAs who bathe, who clean, who shop, who do laundry for people with disabilities. In the home care setting, they may be not employed by an agency, but may get paid through a state waiver program. So they're employed by the individual. They don't have oftentimes health insurance benefits. They're making minimum wage. These are people who may live in poverty themselves. They may be getting food stamps to help meet their own basic food needs. And yet they are the ones that we rely on very heavily to provide this critical role. They oftentimes don't have cars. They're going to have to take public transportation. They're going to travel from house to house. So the direct care worker is one of those populations that if you want to prevent the spread of COVID and protect individuals and keep people in the home, you got to think about them. And yet getting them PPE, getting them the training that they need, they've been invisible in a lot of this. So I wanted to leave time for some discussion. So I'm going to wrap up here by going back to my friend Paul Longmore. In 1995, he talked about how do we deal with this impact? How do we deal with the gulf we have between the disabled, the non-disabled, people without disabilities in the healthcare setting, who oftentimes control the power, the resources, and the relationship with people with disabilities who don't feel well served. You got to bring in the stakeholder perspectives. You got to have the perspectives of people with disabilities, people who work in disability civil rights, people who can attend to the historical and the contemporary oppression of people with disabilities. We've got to bring these voices into healthcare practice, into healthcare ethics, and into healthcare policy. And one of the things I want you to note in this whirlwind tour of where we are at this point in time, it wasn't healthcare workers, it wasn't doctors, it wasn't ethicists that were calling out the disability concerns and discrimination and bias. It was the disability activist. So what do we do moving forward? I think we have to make sure that the stakeholder voices of everyone, but particularly people with disabilities, since they are a particularly vulnerable population, be included in all the planning going forward. Hospitals need to take the ADA seriously. They need to be equipped with accommodations and policies. The ADA is not self-executing, meaning that people have to lodge complaints. People have to advocate for themselves, or go find a lawyer to help them if their needs aren't being met. That's a real problem when you're sick. People don't want healthcare adversarial relationships. So we have to think about, how are we going to solve this issue of ADA compliance? We have to think about, how are we going to address all the needs of people with disabilities during COVID, particularly when they might require more resources and supports up front. This issue of data collection, I can't underscore enough. If we don't understand what's happened, we don't understand where the vulnerabilities and the biases and the discrimination has occurred, those issues of intersectionality, it's going to be very hard to know how to plan for the future. I still think this issue of prevention and pandemic planning and emergency planning is a really ripe spot where we need to think about who are vulnerable and how can we keep them from getting sick, how can we keep them out of hospitals and long-term care facilities. So I'm going to pause there, and I welcome discussion and questions.
Thank you so much, Dr. Kirschner, for that really illuminating discussion and sort of very thoughtful approach to sharing us that information. I'm particularly heartened to hear your suggestions for moving forward, sort of for, you paint the picture, but then you say, here's some things we could focus on. I know Dean Luma has been gathering if there are any questions on chat, but I thought maybe I would kick us off. And just, I really appreciated up front that you focused on the data, and then here you mentioned we need to do a better job. Certainly we've seen that with race and ethnicity data. When it was collected in communities like Chicago, we quickly recognized the disparity in cases of COVID and morbidity and mortality from COVID. And it sounds like that could be happening with disability communities as well. Do you know instances where it's being done well, or thoughts and sort of how we could do a better job to get that data to inform our sort of our policy and our treatment approaches?
So I'll tell you, Massachusetts as a state decided that they wanted their state to collect this data. It's not going particularly well there, but they're trying, which I really applaud. The Office of Minority Health under CMS has not really, they have the 6 questions that have been used in the census, called out as questions that can be used to collect data. It's a problem that it's 6 questions. And so there are people trying to work on how can we maybe have a screening question, so we're not burdening the data collectors in the emergency room, on the front end upon admission to the hospital. So there's a group in Colorado that has a PCORI grant right now working on some of these issues and pilot testing questions. So I think because we haven't done it today, we've got 6 questions, which seems burdensome. I think that's been part of what has prevented people from gathering it. I'd like to encourage, we've worked with the Joint Commission in the past to say, well, shouldn't we be trying to do this as quality of care? Shouldn't, disability access accommodations be part of a Joint Commission review? They haven't seen that as part of their role. They've seen the ADA as a law. Everybody should be in compliance with the law. But I think if we can move in the direction of quality of care and say, look, you need to know if that person's a wheelchair user. You need to know if they require deaf and hard of hearing interpreting services. You need to know, particular information and have it flagged in the chart so it follows the patient. Just like we're trying to do with limited English proficiency patients or people that require, extra services and support, so you can have them in place and you can plan ahead. So I think that, again, we're not at a point where I feel like there's a great model, but I think that there are efforts to try to get us to a better place. And I can tell you there's still an awful lot of advocacy work going on to try to require that disability metrics be collected in healthcare.
Thank you. Thank you very much. Does anyone have, I invite questions if anybody wants to unmute himself and have a question for us.
I'm going to ask you all a question. Does anyone see where the law can help us? Where are the health equity and law interfaces that you can see? Particularly for you budding lawyers out there.
I know, I was going to say, I know we have some students here with us, so, there's your charge. Any thought?
I think there could be some work that we could do on expanding the connection between public accommodations and websites, particularly for the visually impaired, or closed captioning for the hearing impaired, as something that we can seek to apply to more websites and get direct guidance from the Department of Justice and Congress on that.
I like that idea, and I'm going to actually maybe extend it a little bit into the hospital setting. So right now, material and flexible formats is a real challenge in hospitals. We're still dealing with health literacy, the level at which materials are written. If you go into a hospital and you cite a consent form, I really challenge you to think about what that health literacy level is. Do you really understand what you're signing, et cetera? Then imagine that you have an intellectual or cognitive disability, or you have a language disability, or you need services in Braille or audio captioned or whatnot. The idea that we have universal design in our public accommodations in healthcare, it just doesn't happen. Some of the best roadmaps, I think, come out of the disability class action lawsuits. So one of the first class action lawsuits came out of Kaiser Permanente in California. And when you looked at the settlement agreement, there were certain things that they had to do. They had to have a disability services coordinator. So you think about, you come into a hospital and, you may have a situation that your bedside nurse hasn't seen or worked with. Gosh, what a great idea to have somebody you can call and say, I've got somebody who needs an accessible call light, a sip and puff call light, because they're paralyzed. And so I need to have a mechanism for them to be able to call for a nurse. Or they may have a service animal, or we need to know how to get those deaf interpreters in place right away. So you got a disability services coordinator in your hospital that's working on these policies and procedures, working on training staff, and available to help problem solve immediately when issues come up. So I think if you go and you look at some of the settlement agreements, I think that the efforts were really good ones, and ones that we need to take seriously as healthcare systems, because I think that we have so much turnover in healthcare. It's got to be ongoing. It's not one and done. You've got to continually be doing these trainings and reinforcing it and trying to make the roadmaps easy, because I think part of what makes people feel overwhelmed when they get a person with a complex condition in the healthcare setting is the burden is on them to figure it all out. They don't have those helpers or assistants. If they need a particular piece of lift equipment, or, you know, they have to get the interpreter. If you're a bedside nurse, you've got 8 patients, and all of a sudden you have one patient that requires an awfully lot of attention and care. You know, how are we going to support that individual in doing their job? And that's where those disability healthcare stories on the DREDF website can really help you understand that. One of my favorites, if you want to pick one to look at right away, is Jim Lebret. So Jim had spina bifida, which is one of the most complex disabilities. And so you got hydrocephalus, perhaps, you've got, you know, oftentimes a urostomy with a bag that collects your urine, you need bowel programs, you lack sensation in the lower part of your body, so you're at risk for pressure sores. He came in for an unrelated problem to his disability. He needed a hernia repair. And his hospitalization was a nightmare because they just saw their job as doing the hernia repair, nothing, you know, put in place to prevent him from getting pressure sores, to deal with his bowel and bladder needs. He kept saying it. He kept saying, you better get me a special bed to prevent me from getting a pressure sore. It took days. He called ahead to the hospital and said, I'm going to tell you what I need now. And they said, can't do anything till you're in the hospital. So these are the kind of stories where they're solvable. I think these are solvable problems. But we need a lot more training. And I think disability service coordinators, I think legal specialists, people with law training in terms of understanding both the law and understanding universal design. I used that word and I didn't define it, but universal design is you set up your environment to care for the needs of the broadest population without need for modifications. So if you buy high-low tables, they can accommodate people with disabilities. If you think about your bariatric patients, you know, buy a table that's going to meet the needs of everyone, because then anyone can use it. You're not having to say, oh, I got to find a table that can meet the needs of somebody who weighs 500 pounds. Buy all of your tables to be, you know, accessible for people with disabilities, or buy a critical number of them. So that's universal design, and that's an idea I hope takes traction. The Affordable Care Act was trying to move us in that direction, but a lot of the things that were built into it were actually put on hold in 2016, like the equipment issues.
I know we have a few minutes left. Any other questions or comments?
Hi, my name is Zach Sanderson. I am the person who coordinates accommodations for our students here at the law school who have disabilities. One of the things that I have thought was interesting in my time in learning about applying accommodations, and also I think was reiterated by you, is that the like class action or the lawsuits are the ways to get things implemented. And I think when we're talking about access to healthcare and things like that, like access to being able to even go through the process of lawsuits, I think is also difficult when you consider that a lot of individuals with disabilities, like you pointed out, are at intersections of other identities that are often unaware or unable to access things like lawyers and things like that. So what kind of, I guess, like thoughts do you have for folks who are, I'm not a lawyer by any means, I just work at a law school, but what are your thoughts about that for future lawyers or folks who are already in the profession that want to make that more accessible for students, since that is the way to get stuff going with ADA?
Well, so there's a mantra in the disability activist world: educate, advocate, litigate. So you don't want to go to litigate unless you really have exhausted every other option, because it's very burdensome, it's expensive, it takes a long time, but it's a powerful tool if you need it. So I think connecting with your disability advocate organizations for education can be invaluable. Access Living of Chicago is our Chicago-based independent living center. And they have resources on all sorts of things, from housing to education to transportation, you know, to healthcare services. They work closely with Equip for Quality, which is a very prominent disability law firm in the city of Chicago on, you know, deciding what sorts of things to press. So I think working with disability advocate organizations and trying to work across the aisle with people to develop strategies and solutions to problems. You know, in the back pocket, you can always have litigation, but I think if you can try to work through, like DREDF and the ARC, you know, going to Office of Civil Rights. I mean, nobody went to court per se. They used their tools to, you know, get attention to an issue that needed to be attended to. I want to go back to this issue of representation, though, Zach, because your role is so incredibly important. If we don't have equal status relationships in the law, in healthcare, for people with disabilities to work side by side, you know, with non-disabled professionals, then it's a real problem, because I think the most powerful way that change occurs is for us to learn from each other in equal status relationships and to have stakeholder perspectives on the inside. So thinking about your students with disabilities and how we can support them, how we can, you know, help give their voices and perspective space within our professional spheres is really important. And we're doing that in the medical school, healthcare field as well, but we're still not even close to where we should be in terms of just disability representation. One of the issues we're dealing with right now is the issue of technical standards. Do you talk about that a lot in the law school?
Yeah, we discussed that.
Yeah, because in medicine, you know, we have technical standards that say you have to be able to see, you got to be able to hear, you got to be able to start an IV or play, you know, do CPR. And the question is, does everybody need to be able to do all of those things in today's current healthcare world? Most people are going to practice in teams. They're going to practice where they can direct others, you know, to do manual tasks. What do you actually need to be able to be contributing to the world of healthcare? And I think those kind of questions in law are really important as well. I don't know if I answered your question, Zach, but I think community building and working with activists, that's a really important step. And having our Disability Resource Center on campus, you know, thinking about how we build community and how we try to bring issues forward with more than one voice is important.
I had a quick question. You mentioned a disability advocacy organization at the beginning when you said working with organizations. Could you repeat what that organization was?
Access Living of Chicago. Access Living of Chicago is the local independent living center. So wherever you go in this country, there are national centers for independent living. So every geographic area is covered by an independent living center, which is a resource center run by and for people with disabilities that provide resources, education, support for people with disabilities. So it's really good to know about that.
Thank you so much. Yes. I just provided a link in the chat. Thank you.
Great.
Oh, wow. Okay, someone mentioned in the chat that they know someone that does work at Access Living. Awesome.
Well, they do have a law division there too. There are, I think, 3 lawyers at Access Living of Chicago too that are constantly looking at these issues.
Awesome. We have come to the conclusion of our hour somehow, some way. And, you know, I had questions. And so I hope that, you know, we can revisit this topic in different ways. One of the things that I found fascinating was the disability civil rights movement. And I know you had several points in there and I could see some of them, but even that sounded fascinating. And I'm sure attorneys had a part in that whole movement as well.
Well, and I think if you look at those disability legal cases, ethics cases, you can track a lot of what happened in the history, you know, in terms of where we are now and how we got there, because the Paul Longmores were calling out what the judges and the lawyers and the doctors were saying and putting it side by side with the activists.
Wow. Thank you. This has been a depth of knowledge, and it shows how much we've done, but how much more we can do as well. So I want to thank you again, Dr. Kirschner, as well as Dean Campbell, for this conversation, and for everyone for participating and joining us today. We also have another disability awareness program, October 28th, where we're going to invite the Disability Resource Center as well as the Disability Cultural Center to see how we address disabilities, not only on campus, but also university-wide, and just what resources are available, and also what issues are kind of prominent right now in that area. So thank you again, and I hope to see you all again for our next program this month. Take care, everyone.
Thank you so much for having me.
Thank you.